All right, nerds. I got a bunch of requests to do just a basic EKG lecture, not all this fancy stuff I'm talking about. So here it is. I hope you enjoy it. A couple things. Okay, number one, remember we don't treat an EKG, we treat a patient. Okay, and the value of any EKG depends on your pretest probability. Those are the main things I want to take you away from this. Okay. Second, when I first started, I had no idea what I was doing. And the two things that helped me out is number one, to come up with a system. Okay. The system that I like is this system, and it just so happens to be all the things that you need to bill for interpreting an EKG. Rate, rhythm, axis, intervals, ST waves, and then lastly, always compared to a previous. For the rate, comes what I think is it fast, slow, or normal? For rhythm, is it sinus or not? For axis, it's either left, right, normal, or indeterminate. For the intervals, I'm specifically looking at the QTC interval and the QRS interval. For the ST waves, what I'm looking for is J-point deviation, hyperacute T waves, or inversion. And then, like I said, number 6, always help to compare to a previous, okay? Because normal and abnormal is my least favorite term in medicine. The definition of normal means conforming to a standard of what's to be expected, and that's different for different people. Like, you have to look at what their quote-unquote normal is from the previous EKG to help you identify any changes in any pathology. Just some basic terms here, okay? So the P wave always precedes the QRS, and it is a sign of atrial depolarization. This whole thing right here is called the QRS complex. So let's go over the terms, okay? The Q wave is the first downward deflection after the P wave. The R wave is the first upward deflection after the P wave. And the S wave is the first downward deflection after the R wave. Okay, let me say that again. Q wave, first downward deflection after the P. R wave, first positive deflection after the P. S wave, first negative deflection after the R. So they call this whole thing the QRS complex. So that means depending on what's going on and what lead you're looking at, sometimes there's a Q, sometimes there's not. Sometimes there's only an R wave. Sometimes there's only an S wave. It depends on what's going on. So don't forget that terminology. And remember, a pathologic Q wave is one that's greater than 1/4 of the amplitude of the QRS. You can see in this normal example, this is not greater than 1/4 of the amplitude of the QRS, so it's not pathologic. Okay. The T wave represents ventricular repolarization. Sometimes there can be a U wave, sometimes there's not, and then it goes back to the P wave. Okay. The PR segment is the time frame from the beginning of the P to the beginning of the QRS. The QT interval is from the beginning of the QRS to the end of the T. The ST segment is from the end of the QRS to the beginning of the T. And the J point, which they don't mark here, is the ending of the QRS. Okay? That's what the J point is where the QRS ends. So those are the terminologies, okay? Q the first downward after the P, R the first positive after the P, S the first down after the R, J point is where the QRS ends. All right? Now, like I said, number 1 is to come up with a system. Number 2 is to remember, well, what a normal EKG is supposed to look like, right? Because that's how we identify pathology. How is this EKG different than normal? How is it different than their baseline? And what does that mean? Now, these are my rules, and this is how I remembered it, okay? So for a normal EKG, all I did was divide the EKG right down the middle, okay? Everything on this side is supposed to be positive with the exception of AVR. AVR is inverted, okay? When it comes to this side, okay, what's normal is first, look at the R wave in V3. If it's over 3 millimeters, that's good. Number 2, look at the R wave in V2 and V1. That should be less than the R wave in V3, okay? Over here in the lateral leads, you should not see an S wave in V6, all right? So that's my simple, normal explanation. Everything to the left of the middle is positive with the exception of AVR, okay? On the right side, first look for an R wave over 3 millimeters in V3. Make sure the R wave in V2 and V1 is smaller than V3, and make sure there's no negative deflection in V6. If you have all those things, boom, it's normal. Now, believe it or not, it's very hard to find an example of a normal EKG on the internet. This was the best one I could find. The only thing that's not technically normal here is this T wave in V1. Technically, that's supposed to be inverted, okay? I mean, technically, V1 and AVR are supposed to be like bros. They're supposed to look exactly the same. So that's how I started, right? Number one, come up with a system. Number two, what's a normal EKG? How does the EKG differ from what I'm seeing? How does it differ from the previous? And what does that mean? All right, for the rate, okay, for me, what I'm worried about is it fast, slow, or normal? In real life, just use what the machine tells you, okay? There's a bunch of fancy stuff that you can use, which is good for tests and everything, specifically like these boxes, okay? Each 1 millimeter, why does it do that? Each one small box is 1 millimeter, which corresponds to 0.04 seconds. A big box is 5 millimeters, which corresponds to 0.2 seconds. Okay. The x-axis is time. The y-axis is voltage. Okay. One small box on the y-axis is 1 millimeter or 0.1 millivolts. For the vertical ones, okay, two big boxes are 10 millivolts 10 millimeters or 1 millivolt, okay? All right, so fancy things that you can do. This is from like a website online. You can, like they say, count the number of small squares between two R boxes and divide by 1,500, which seems kind of complex to me. Another thing you can do is this whole EKG is just 10 seconds. Okay, so you can just count each QRS beat and then multiply by 6. That's another trick you can use. But I mean, these tricks are cool for tests and stuff like that. But in real life, the machine gives you the numbers. Just use those numbers. But be cautious because the machine can't think for itself. Sometimes if there's very tall T waves, the machine gets confused and counts those as R waves. So always be smarter than the machine. Okay. The next thing we're looking for is the rhythm, okay? And for me, the question is there 1P for every QRS? Okay, so for the EKG, everything up here is the EKG, all right, like all the leads. 1, 2, 3, AVR, AVL, etc., etc. At the bottom, this whole thing is called the rhythm strip, okay? And the rhythm strip is always either lead 2 or V2 because those are the best place to see P waves. And you read the rhythm strip just like you read a book from left to right. And the question is there 1P for every QRS? So P, QRST, P, QRST, P, QRST, P, QRST. So there's 1P for every QRS. We're sinus and we're done. Move on. Okay? Patrick. All right, now as far as AV nodal blocks go, okay? When you're talking about blocks and EKGs, make sure to use specific language. There's 3 different types of blocks that we refer to. What we're talking about here is AV nodal blocks when there's a problem for electricity getting from the atrium to the ventricle. Other blocks is a bundle branch block where the QRS is wide. The third types of blocks are fascicular blocks, which we won't go over here. A first degree AV block is just a prolonged PR interval. I mean, it's cool to identify in a test, but clinically, I'm not concerned about it because it doesn't really cause any pathology. This is an example of just normal sinus rhythm. Again, 1P for every QRS. We're done. Move on. Okay. Now, when you come to a situation where you're reading the rhythm strip, and if you're asking yourself, is there 1P for every QRS? And the answer is no, you have to stop and think. Okay, so let's read this rhythm strip. P, QRST, P, QRST, P, no QRS, okay? PQRST, PQRST, PQRST. So now we can no longer call it normal sinus rhythm. We have to stop and do some investigating. When you come to this point, my recommendation is to check 2 intervals, okay? Number 1 is the P to P interval. Number 2 is the PR interval, okay? For AV nodal blocks, the P to P interval should not change. Let me say that again. For AV nodal blocks, the P to P interval should not change. And when we look here, okay, here's 1P, there's 1P, there's the interval, okay? same interval, same interval, same interval, same interval, same interval. So the distance between each P wave does not change, okay? Now, let's look at the PR interval, okay? Here's one PR interval. Here's another one. There's 0. Here's one. Here's one. Here's one. Now, if the PR interval is changing, that's a second degree type 1. If the PR interval stays the same, it's a second degree type 2, okay? It's that simple, all right? That's how I remember it, okay? Now, this, it is an example of a premature atrial contraction, okay? Now, like we did before, let's go through P, QRS, P, QRS, P, QRS, P, QRS, P, QRS, P, no QRS. However, when we look at the P to P interval, it's changing, okay? This P to this P distance is the same as this P to this P, but look at this difference, okay? This distance is much shorter. This is a premature atrial contraction that is blocked, a PAC. This is not a heart block. This is not atrial fibrillation. Blocked PACs are most often overcalled as these things. Be smarter than everybody else. When you see one P without a QRS, look at the P to P interval and the PR interval. If the P to P interval is changing, it's a PAC. If the PR interval is changing, it's a secondary type 1. If the PR interval stays the same, it's a second degree type 2. All right. Now, for this one, let's go through it. All right. So we're looking, and the question is there one P for every QRS? P, QRS, T, P, no QRS, P, QRS, T, P, no QRS. All right. So let's go through. Let's look at the P to P interval. Here's one P. Here's one P. Here's one P, here's another one, here's another one. The P to P interval is not changing. Now let's look at the PR interval, okay? PR interval, PR interval, PR interval, PR interval. It's not changing, okay? So now we have a second degree type 2 AV nodal block, all right? Now, like we talked about, let's go through this and see what our rhythm is, okay? P, QRST, P, QRST, P, QRST. Look it, there's a P without a QRS, correct? Now, let's go through and see our P to P interval doesn't change at all, okay? Now, when we look at our PR interval, it's all over the place. I know I said, look at the PR, and if it's extending, it's a secondary type 2, but this is a unique situation where there's no connection between the P waves and the R waves. Like, look at this. Like, the R to R interval remains the same. The P to P interval remains the same. And there's no connection between the two. That is a complete heart block or third degree heart block. All right, now the next thing is axis, okay? Now, an easy rule of thumb, literally, for access is to use the thumb rule. And what you're looking at is lead 1 and lead AVF. And you put your thumb in the direction of the majority of the QRS. So up here in lead 1, it's up, so my left thumb is up. Up here in lead 2, it's up, my right thumb is up. 2 thumbs up, it's normal, okay? If it's up in 1 and down in AVF, okay, your left thumb is up, so it's a left axis deviation. If it's down in 1 and up in AVF, okay, it's up in AVF, your right thumb is up, so it's a right axis deviation. If they are both down, okay, 2 thumbs down, and classically that's called an indeterminate axis, you can't tell. All right, so that's the easy way to tell axis. 1 is your left thumb, AVF is your right thumb. If your left thumb is up, left axis, right thumb is up, right axis, 2 thumbs down, indeterminate, 2 thumbs up, normal. All right. Again, here's an example of it, okay? Up in 1, down in AVF, okay? So we're in this left axis deviation area, okay? And this graph highlights what an axis should be. Okay, the normal axis is in this region right here. Okay, if you're over here in this region, it's called a right axis deviation. This is like the extreme axis or like the indeterminate or the northwest axis deviation. And again, this is off topic, but for me, anytime There's an S wave in lead 1. I'm always concerning that right axis deviation. Because when it comes to axis deviation, left axis deviation as an ER doctor, I don't really care about. Right axis deviation to me is concerning, and I need to investigate more and see my other videos for more information on that. All right, and here's an example of right axis deviation, okay? It is up in AVF and down in lead 1, okay? And again, I mean, all this fancy stuff, it turns out to being here in this right axis as far as electricity goes. Now, for the intervals, like I said, for me, what I'm concerned about is prolongation of the QRS or QTC. In real life, I just use the machine. The machine will give you the numbers. For a QTC, a good rule of thumb is the T wave should not fall halfway between each R wave. There's one R, there's one R, here's the midpoint. The T wave does not hit that point, so the QTC is not prolonged. For the QRS, the technical, it's 3 boxes. If it's longer than 3 boxes, then it's a prolonged QRS. Again, in real life, I just use the machine for those numbers. Here's an example of a prolonged QTC. Again, the machine would give you these numbers, but as you can see, okay, here's one QRS complex, here's another QRS complex, here's the midpoint, and the T wave does intersect there. And a prolonged QTC is good to know about because it puts you at risk for torsades. And lots of medications we give you can make your QTC longer, and we don't want to induce that. Next, for the intervals, okay, here's an example of a wide interval, okay? As you can see, the QRS and the precordial leads is bigger than 3 boxes. It's greater than 120, okay? So when you see a QRS greater than 120 with a P wave, okay, the diagnosis, and there's no, with a P wave and no pacer spikes, the diagnosis is a bundle branch block, okay? There's a bunch of criteria for bundle branch block. There's simple rules to use, okay? So here's my rules. Number 1, is there the QRS greater than 120, and is there a P or a pacer spike before every QRS? If the answer is yes, then look at the precordial leads, okay? If they're down in the precordial leads, it's like you're pushing your turn signal down to turn left in your car, and it's a left bundle branch block. If they're up, it's like you're pushing your turn signal up to turn right in your car. It's a right bundle branch block. Another thing you can do is take the EKG and rotate it 90 degrees to the right, okay? If these QRS complexes are pointing to the left after you do that, it's a left bundle branch block. If they're pointing to the right, it's a right bundle branch block. It's that simple. That's all you need to know. Another thing I'd like to point out is that normally in a left bundle branch block, it is appropriate to see left axis deviation, all right? And that's part of the criteria for a left bundle branch block. But just keep it simple. Greater than 120, if it's down in the precordial leads, it's left. If it's up in the precordial leads, it's right, okay? Here's an example of a complete right bundle branch block, okay? Let's answer the questions. Number 1, is the QRS greater than 120? The answer is yes. Is there a P before the QRS? The answer is yes. So it's either a left or right bundle branch block. These QRSs are pointing up in the precordial leads. And if we rotate it 90 degrees to the right, these will be pointing to the right, so it's a complete right bundle branch block. One thing I would like you to note is that in a right bundle branch block, there is no axis deviation normally, okay? If you ever see a complete right bundle branch block and axis deviation, that should heighten your concern for something going on. All right, now the last thing, so we did rate, rhythm, axis, intervals. The last thing is ST waves. And like I said, for me, what I'm looking for is J-point deviation from the PR segment, hyperacute T waves, or inversions. So let's go through this EKG. Let's start up here in lead 1, okay? There is the PR segment. There's the J-point. There's no deviation. The T wave is not hyperacute, and it's upright as it should be, which is normal. Same issue here, no J-point deviation and T-wave is upright. Same issues here, okay, no T-point deviation. I mean, technically the T-wave is flat, which, I mean, some of you got to report, but again, no inversion. Let's look up at AVR, okay. There's the PR segment, there's the J-point, no deviation. It's supposed to be inverted, so it's not, there's no T-wave inversion. Same thing AVL, no J-point deviation, T-wave is flat. AVF, no J-point deviation, T-wave is upright. V1, okay, no J-point deviation, but the T-wave is upright. Technically abnormal, like I talked about before. V2, no J-point deviation, T-wave upright. Is that hyperacute? Well, maybe. We'll talk about that later. Okay, V3, no J-point deviation, the T-wave is upright. Same thing, V4, V5, and V6. No J-point deviation, and the T-wave is upright. Okay, and also remember our things before. What we looked at is we have an R wave bigger than 3 millimeters in V3 and no S wave in V6. All good normal signs. All right. This is what I was talking about with J-point deviation. Okay, because so you can call it, if you want to, ST elevation or depression, but for me, I qualify it more as J-point deviation because that's what concerns me for the signs for ischemia. Like up here in normal, you can see the J-point falls along the isoelectric point. And again, there's two ways to tell the isoelectric point. One is the PR interval. The other is the TP, or the ending of the T to the beginnings of the P. I always recommend using the PR segment because the TP segment can get jacked up. See my other videos. Here we have a sign of J-point deviation, which is ST elevation. Same issues here, okay? And here we have J-point deviation or J-point depression, all right? Again, here's an example of real-life evaluation, and let's go through it. Well, let's just do the whole thing, okay? So for the rate, I don't think it's fast. For the rhythm, I do see 1P for every QRS, so its sign is maybe a first-degree AV block, but who cares? For the access, it's up in 1 and up in AVF, so normal access. For the intervals, I do not see any prolongation of the QT, and the T wave does not fall halfway between each QRS, so I see no prolongation. For the ST waves, I see many abnormalities. Okay, number 1, we have J-point depression in lead 1, lots of J-point depression in 2 and 3 as well. Okay. Not only that, but the ST segment is inverted or below the isoelectric point, which is also abnormal. In AVR, we have J-point deviation, which is J-point elevation. Okay, not much in AVL. I mean, the J-points maybe a little bit, nothing too crazy. Wicked J-point deviation in AVF. We also have J-point elevation in V1. Okay, we do have. I mean, let's look at this and let's use what we learned. So here's the P segment. There's no Q wave. We have an R and a S wave, and this would be the R prime. Okay, so an incomplete right bundle branch block appearance, and yes, there is some J-point elevation. In V3, J-point depression. V4, 5, and 6. All right, look at that. Wicked J-point depression. Okay, those are all bad things, right? So overall, my findings, if I was talking to you on the phone, I'd say I have a normal sinus rhythm, first degree AV block, normal access and normal intervals. There appears to be J-point depression in multiple leads. So there's J-point depression in 1, 2, 3, AVF, V3, V4, V5, and V6, and there's J-point elevation in AVR and V1. I mean, even if you don't know the diagnosis, I mean, that's a STEMI. Like anyone who knows anything knows that's a STEMI. So that's how this whole process works, right? And when I compare this to normal, you're not supposed to see J-point deviation in those leads and or T-wave inversion leads, so it's abnormal. Okay. Here's an example of hyperacute T waves. Now, hyperacute T waves are more tricky because it's more subjective. Okay. Here's some fancy nerd math science stuff where they're defining hyperacute T waves based on their increased area, which I think is dope, right? I mean, because if you get straightening of the ST segment, that'll increase your area. And if you get J-point elevation, that'll also increase your area. That might be something interesting to put math into the computer and make it do, but that's besides the point here. In general, what you're looking for a hyperacute T wave is not necessarily how tall it is, but how tall it is compared to the QRS, right? Like this T wave is almost approaching the same height as this QRS. And Amalma 2, the godfather of EKG, always says, well, if you can fit the QRS under the T wave, that's hyperacute. So it's not necessarily how tall they are, it's how tall they are in comparison to the QRS and also how narrow they are. I mean, look at this one. That's what's taller than the QRS, and looks how narrow as well. So hyperacute T waves is more of a subjective finding, hard to quantify, but something to look for in your evaluation, in my opinion. Ooh, look, I mean, I didn't mention that, but look at this. Look how ugly this is. Like, look at AVL. I can't help but notice it. There's J-point depression and inversion and linearity. Oh, that makes me nervous. Ooh. All right. Again, more nerd stuff about hyperacute T waves. All right. You can look up the paper and read on if you want, but my overall interpretation is, I mean, it's more subjective than anything else, but something you should definitely be looking out for. And again, here's an example of real-world hyperacute T waves. Let's just go through and do the whole exercise. Okay, the rate, I'd say, is normal. The rhythm, we have 1P for every QRS, so it's sinus. You can kind of peek at the P waves when you're doing your rhythm strip evaluation, and you can see they're kind of large. We go up here to V1 and V2, biphasic sign of left atrial enlargement. Okay. Rhythm rate access up in AVF, up in 1 is normal. Okay, for the intervals, I don't know, maybe an incomplete right bundle branch block. I don't see any definitive widening of the QRS or the QTC as it does not fall between each R. Ooh, let's look at the ST waves. Okay. Ooh, look at AVL. Yeah. Look at that inversion. Look at that linearity, especially compared to the amplitude of the QRS. Okay. Look at lead 2. Look at this. This entire QRS can fit under there. Okay. Amalma 2. Don't forget it. Same thing here. This entire QRS can fit underneath this T wave. Same issue here. Like these T waves are taller than the QRS. Look as well here. Look at these. Like look how tall that is. Same issue here. That entire QRS is fitting underneath the T wave. Okay. I mean, global hyperacute T waves are most often associated with hyperkalemia, but focal hyperacute T waves can be a cause or concerning for infarction or ischemia, which I'm worried about as an ER doctor. All right. So that's all I got for this one. I hope you enjoyed it. Okay. To review, the steps are sixfold: rate, rhythm, axis, intervals, ST waves, and compare to previous. For the rate, is it fast, slow, or normal? For the rhythm, is it sinus or not? If you have 1P for every QRS, you're all done. If you don't have 1P for every QRS, then map out the P to P interval and the PR interval. Axis, 2 thumbs up. Your left thumb is 1, your right thumb is AVF. Left thumb up, left axis, right thumb up, right axis. 2 thumbs up, normal. 2 thumbs down, abnormal. For intervals, we're worried about the QTC and the QRS. You can use the machine in real life, but the QRS should not be over 3 boxes, and the QTC should not fall halfway between each R wave. For the ST segments, you're looking at the J point, and what you're worried about is J point deviation from the PR segment, T wave inversion, or hyperacute T waves. And then number 6, always compare to previous. And again, my definition of a normal EKG is everything on the left is positive except for AVR. On the right, first you go to V3. You want an R wave over 3 millimeters, and you want an R wave in V2 and V1 to be smaller than that. And then the QRS should be positive in V4 through V6, and you should not have an S wave in V6. That's all I got. I hope you enjoyed it. If you didn't and you don't like my rules, don't use them. I don't care. That's all I got. Peace out.